Okay, here we are. Everyone's coming on. This is the beauty of technology. I know, see, Hassan, we are incredibly technology compliant.
Noon, everyone.
Andrew, I think you stopped my video earlier on when you have to undo that. It says the host stopped my video.
Hey, I got you.
Mine as well.
Okay, so wow, thanks everyone for being incredibly punctual. When we are done with this session, we will have had 7 hours and 15 minutes of continuous education. So it's been unreal. This year was the smoothest we've ever had. I went back and looked at last year's video and I did not say that. So I think I really mean it this time. It was great and all really because of you. And we're getting a lot of great feedback from people out there. So thank you to our incredible speakers. Also, thank you to Miguel and Tony and everyone in our IT world because this was, believe it or not, not easy. We probably should have hired somebody like Hassan, but it all worked out. Now, the panelists cannot see. Hey Matt, the panelists cannot see the audience, but the audience can see you. And we've gotten a lot of questions to the audience. There's no possible way we're going to get to all of your questions. We will forward them to the appropriate panelists and get you answers. But for now, if you have questions during it, you could put it in the question and answer box, but I won't get to them till the end. And you can just call any of our 6 offices and leave your questions as people were doing with the receptionists, and we will get back to you. Speakers, you're all experts in your field, but you know a lot about other fields. Feel free to argue with each other. Yeah, we got Bob Getling's usually good at that, so feel free to reach out across Center Square and ask each other questions. It makes it more dramatic. If you start fighting with each other, that's even better. We actually have a trained psychiatrist who might be able to help you with your anger management problems in Dr. Aldat. So I'm gonna start this along the chronological order of the agenda, and that gets us to preparing for and defending payer audits. So I'm going to start that. For those of you who didn't listen, I'll try to summarize, but that was about how to defend and prepare for payer audits. Rob, I got the same question from several people, so I think it hit a nerve. You mentioned during your part of your presentation how important it is to not change a record, because if you change a record and submit it, that could be a crime. The question that we're getting from a couple of people is, well, when can I supplement? Oh, I forgot the lab thing. I'm going to put the lab thing in now. And where is that line between putting together a thorough record and getting in big trouble?
Okay, they're great questions. Um, at the time of an audit, it's generally not the time to be changing your records. Okay, so at the time that request is coming in, that isn't the time. So when is the time? You have 3 real categories that you can fall into in order to do that. It's the late entry. Okay, so that is it's close in proximity when that patient encounter was, and I remembered something that took place. I can go in and add that. Okay. An addendum, a report came in from a diagnostic test, okay, that I now interpreted or looked at or is impacting my plan of care. I can go in and do that. Or I noticed a mistake. I remember I typed something or I looked back at something and I realized I need to correct something. Those are appropriate circumstances in which you can change your medical record. or really the right word is amend or supplement your record, because what you can't do is go in and delete anything. You can't remove the existing content. Okay, if it's a paper record, you would need to cross it out in a manner that a reader could still read what was there. For your electronic health records, you need to be doing it in order that it is a supplement. So if that you printed the record, you'd be able to see both the original content and the changed or addended or added content. And it always needs to be signed and dated and done in a way that indicates it was added at a later time. So that's really the other thing I'll tell you is you really shouldn't be going in and changing other people's records. So if you're a provider out there and you're reading the records in relation to an audit or something else, it should really be the person who's doing it or who entered the original note doing it. And you never want to delete information and make it look like as if something happened that didn't, as if it was contemporaneous when it really wasn't. So those are the ways to do it. Those are the ways not to do it.
And Rob, I'm reminded of one particular case you and I worked on, but I suspect you've had many more, where the provider would have probably gotten away with what he's being accused of, but then gotten a whole bunch of worse trouble because they fabricated some records.
100%. It happens all the time. And the other area, because the case you're talking about reminds me too, is what about those signatures? You didn't sign and lock your chart. Okay. So signatures, like the Medicare rule is they don't accept late signatures, but they do accept attestations. So that was the one other area I just wanted to touch on now that you mentioned. There's been a few of those cases where I've had to walk into either U.S. attorneys' offices or attorney general offices and try to walk things back for clients, and it has created, things that would have probably gone away into much, much more catastrophic circumstances for the client.
Right. And, I'm looking at the panel and I see this touches a lot of different areas. So whether you're getting a business ready for sale, which there's people on here we'll talk about, and they go and start messing with records, or you're getting ready for an accreditation thing and you start making stuff up, you just can't do it. And if you have a question, I'm sure, Rob, you or someone on your team can answer. So Deb,
Always.
I just got a text from a client saying, don't mention that I asked this question. So don't worry, anybody out there in TV land, I'm not identifying. But this is a classic question that I get all the time. I'm sure Rob and his group gets all the time. If I really put up an aggressive defense against a payer, whether it's commercial or government, doesn't that make it worse for negotiating? Won't they take the position, no, you busted my chops, so now I'm shutting down? Because that's what I think sometimes investigators even imply to providers. But how do you react as somebody who deals with payers all day?
What I say to clients, and I do get this question all the time, the good news is these plans often are so large that the investigative units, the special investigative, the SIUs, they're completely separate and apart from the teams that are negotiating contracts. So that's a good thing. Also, these health plans, and what I should say is the right hand doesn't always talk to the left hand. And we've had situations where I've done a complete contract only to find out later that the party who signed the contract was actually under prepay review. And we didn't even know during the entire time of the contract negotiation, which took over a year. So again, these health plans are behemoths, and the right hand doesn't often know what the left hand is doing, meaning that you heavily and aggressively can defend your audits. And I don't see it having ramifications on your contractual activities. However, what you don't want is, and I think we talked about this a little bit during our presentation, is that you can't ignore an audit, because if you ignore an audit, you end up could go into prepay review or something like that. And then that absolutely does impact how the plans look at you on contract negotiations.
So fighting is okay, right?
Fighting is okay. Look, health plans, they're big boys and girls. And for them, it's never personal. It's usually just money. And so they expect you to put up a defense.
Right.
Even though their letters always say, we've audited, thank you for your records, we've audited, now please send us a check for $1 million. They don't really expect you just to cut the check.
I just want to say you're entitled to a defense as well. Okay. And I don't have a problem pushing back on these plans. We do it all the time. And some of the investigators sometimes like to throw things around to scare and bully our clients, and they need to be pushed back on.
Right, and I would also say two things, and then we're gonna move on to navigating adverse outcomes. But one, do not take legal advice from your billing company. Okay, the billing company may be the source of the problem, and they're not lawyers. Like, I wouldn't take billing advice from me necessarily, right? And the second thing that I would say is, and we're having this more and more, for the physicians who are out there in TV land, you're very busy, you're running around, and you're delegating a lot to your administrative staff. I don't know that you need to be involved with a request for 1 or 2 records, or for a request for 50 records from CMS. Yeah, they should come to tell you about it. We've had many instances where the front office staff, administrative staff, was responding to CMS, and by the time it was Rob or Deb's team got involved, it was too late. So stay on top of your administrative and tell them what you expect. Okay, going on. Navigating adverse outcomes. So you're in any organization, hospital, ASC, and something happens, and a physician is investigated internally, and there are times, if you listen to the session, where you have to make a report to the National Practitioner Data Bank. It can be career-ending for a provider. It is extremely serious. So, Len, where are you? Oh, I realized I skipped Simon, so I'm gonna come back to you. Len, wave your hands right there. You go. Okay. So, Len, a doctor gets reported, he has the right to self-query, and he'll look and see his own report, and he disagrees with the characterization of how the ASC reported him, or whoever reported him, the hospital, OPMC reported him. Is there anything the provider can do at that point?
There are multiple things the provider can do, but first, you should know that a self-query is not necessary, because the data bank will mail a copy of an adverse action report to the last known address on file for the provider. The first thing that the provider can do is file what's called a subject statement. It's a response to the report. And you've got a character limit, but basically the practitioner can provide their view of things and rebut whatever they think needs to be rebutted. We always recommend that the physician who's going to do that should consult with counsel, because sometimes the subject statement, if properly drafted with good advice, can be very helpful, and sometimes it can be self-destructive if it's starting, with conspiracy theories and whatnot. So that's the first thing the practitioner can do. The next thing, there is a box that the practitioner can check to put the report in dispute. It'll be an empty box, and it'll just say dispute or not. So that way, when any other entity queries the data bank and sees the report, they will also see the subject statement at the same time. They will also see that that box dispute is checked. The next thing the practitioner can do is to contact the reporting entity and ask that the report be changed, corrected, voided, whatever. That usually doesn't produce the desired results. And if it doesn't, the physician can then invoke what's called the data bank dispute resolution process. There's an entire administrative process whereby the physician can ask the data bank to investigate the circumstances that led to the report and make a determination whether or not the report was properly made. And this is handled through the Department of Health and Human Services. They have their own data bank division that does this. It's done only on papers, and they do not evaluate the quality of care provided or whether or not the opinions of the people who imposed the corrective action were warranted or not. All they do is look at the facts and circumstances and determine whether is properly made under the statute and regulations. If at the end of that process, the physician still feels aggrieved and believes it's a serious enough matter to take it further, they have the right to file a lawsuit in federal district court under the Administrative Procedure Act to seek to annul the determination of the data bank not to void or change the report.
Okay,
There's a whole menu of choices.
so it sounds like you're not, if you're a provider, you're not without ability to dispute. If it were me, I didn't realize the letter gets sent to you, but if I were a doctor, hey, Matt, I think I would, I might self-query just to see what people have said about me. Because maybe I missed the letter. God knows I miss half the mail that comes to me. Interesting. So Stacy, so let's say a doctor does something wrong, gets disciplined by the entity he works for. I'm the patient now. We're all patient. We've gone to see a doctor. Will I be told that my doc did something wrong? Maybe on my case, I really would want to know. Will I be told?
No. You will not be told that an adverse action has been taken against the doctor or your provider. Now, if the adverse event itself is of the type that the Joint Commission requires you to be informed happened, such as certain mistakes, the Joint Commission requires that the event be told to the patient. And I believe New Jersey law has a similar requirement that the negative thing that happened to the patient be told to the patient. But the patient is not informed of what actions are taken against the provider. That probably would just be a recipe for a mid-malaction, so. In New York, there is also a law under the public health law that requires certain things that physicians post on their profile, such as if action is taken against them. So if the licensing board puts someone on probation or something like that, it has to go into the physician profile, which is searchable by the public. But it is not just the fact that hospital A even suspended a doctor, the hospital A would not reach out and tell the patient that.
Okay, quite scary. So it sounds like if you're going to a new doctor, or even when you have, might not be a bad idea to check some public databases if they've been.
Right.
I guess it's different in every state, but I think most states would have. You could look up, see if actions have been taken, right?
Right. Also on the various boards' websites, if action is taken, it'll be listed. But the board has also the profile, which is a little different.
All right, so I'm watching the time, which always seems to go way too fast. I'm gonna come back to Simon for a second. So Simon, somebody actually asked this question, even one we talked about in the prep session. I'm assuming that payers and the government use certified coders, which you are. I should have introduced you. Simon is a member of Garfunkel Health Advisors, which is a coding company that we own. If they're using coders and you're a coder, are you really going to find anything that they did different? Because aren't you all reading from the same Bible?
Yeah, sometimes audit finding results are complex and they do require in-depth knowledge of your Medicare coverage determination, payer policies, and other nuances of medical record documentation. As subject matter experts, they will assess your medical record documentation to determine if you do have a defensible argument. For example, the information in the pathology report might have not been submitted or available at the time of completion of the operative report, but it does serve as additional information that could be used in a defensible standpoint. So many health payer audits have auditors that spend maybe 1 or 2 minutes skimming through the medical record documentation. So there is a high chance that they might overlook certain things. So it is recommended to have an independent auditor go through the medical record documentation to see if they agree or disagree with the payer audit findings.
Yeah, and what I would add, which is obviously self-serving, but I think needs to be said, if you hire a law firm like GW that happens to own a coding company, we can put that all under privilege because you don't want you're saying, yeah, I actually think CMS is right to be something that's discoverable. So, okay. Moving along, we had a very lively discussion from the perspectives of buyers and sellers in transactions, and I got at least 2 texts from doctors saying questions about selling their facility. But first, I'm going to ask Scott Davis, where are you? There's so many people, I can't. There you are. Okay, great. So, Scott, we're in an election mode, and everyone's not sure of what the next 7 days are gonna bring to us. But I bet you get asked this question all the time. Where is the where do you see, I'll give you a crystal ball, where do you see the market going in terms of sales of medical providers, let's say in the next 12 months?
Yeah, I guess I'd start probably with the broader kind of healthcare market and M&A activity. So we're putting out our Q3 kind of write-ups and newsletters and stuff like that. It'll go out to people in the next couple of days. And what it allowed us to do is look back at the production in Q3 versus earlier this year and years prior. And what we saw was a relative rebound in overall deal activity for the past 3 months. Now, that could just be a point in time, doesn't necessarily mean that it'll continue in the go forward, but what it also coincided with was the interest rate cut by the Fed, which generally speaking will work its way down to the middle market to lower middle market and M&A transactions over a period of time. So I think those 2 indicators are pretty encouraging for this year and beyond. Andrew, your question was specifically around, it sounded like physician practices. I would say that kind of broader subsector is one that's definitely going through some changes. I would say even in the last 12 plus months, all things being equal, I'd say interest from the investor community is slightly down. The offset to that is interest in things like outsourced services that from the investor standpoint gives them access to a lot of the same tailwinds in terms of supply demand imbalance and things of that nature, but without some of the same inherent risks like reimbursement or labor costs or controlling a wide swath of physicians and keeping them engaged. Having said that, we're not thinking that physician practice deals are going to drop off by any major amount. We here at Provident have largely been focused on that for the last 10 years of our firm, and we're going to continue to be largely focused on it moving ahead. That's the expectation. It's more to point out the fact that there may not be the same rapid amount of platforms developed if we're talking about private equity and or the same kind of premium valuations that there once were. Again, not to say there's not premium values to be had, but some of these really high flying numbers that candidly are the ones that sellers like to tell their comrades about in their industry that may not be there for every single group moving ahead. That could be part of it as well. So I think deal flows up. I think physician practice interest will remain strong. Do I think it's as strong as it was in, say, 2020, 2021? Probably not.
Okay, well, that's an honest assessment. So, David, we have Scott, and right below him, if everyone has the same configuration, Bob Gedling. So I have 2 investment bankers. For those of you who don't have your agenda right in front of you, David is the Vice President and Acquisition Development of Surgery Partners. So you're a buyer, okay? Recognizing that you don't want Scott and Bob to beat you up and say nasty things. What is an investment banker in any transaction helpful, and in what ways do they help a buyer, and what ways do they help a seller?
Yeah, sure. Thanks, Andrew. To us, it's when brokers, investment bankers are involved, it really shows an indication of commitment on behalf of the physician partners, commitment to the transaction, a commitment to the process, which is when a broker is involved is defined with a process letter, a timeline, certain events, when an indication of interest is due, and then a letter of intent is due, and really the ability to educate the physicians early on prior to any management meetings is valuable. And for us, their ability to gather quality data to provide to potential buyers is important. They know what it is that the type of information that buyers are looking for, and they package it in a way where it really streamlines the time process. So that's very important. And then, not to be overlooked, kind of the communication buffer that they provide, kind of between a buyer and seller, so they can kind of gather various points of interest or concern or focus points and really present something that's more unified. And then when you get down to a letter of intent, then they can present those comparisons. If you have 5 different offers that kind of make the first round, then being able to explain to the physicians the pluses and minuses and the pros and cons of each one of those offers in an intelligent way is important to the physicians for sure. And, ultimately, when the physicians do choose a partner, they're doing so by having gone through a defined process. And when they do choose a partner, they're ultimately happy with all coming to the conclusion that this particular partner is in the best interest of the overall partnership and what is kind of 2.0, if you will, once you jump the broom with being that partner. So they're more committed to kind of the future that, we all agree that this is the way to move forward. And the broker helps that out.
Wow, that's fascinating, because I get doctors that say one thing, or really not just doctors, but we just sold an ASC a couple days ago. They say that they don't know if the buyer will be put off if they get an investment banker. What they really may be saying is, we don't want to spend the money. But I can now say, my takeaway from what you just said is, you actually like that there's an investment banker. If you had your druthers, you'd want there to be one.
I would. We just had great success with really the process and the way that process is defined. When, if the doctors make a decision to invest in an investment bank or a broker, then that's a big statement in and of itself. You often find, and we've got over 160 surgical facilities, so there are a bunch of them that were done without brokers, and that's fine. And sometimes that works quite well, working just with the physician leadership. But within that physician leadership, you can have a bunch of different opinions, and sometimes that is helpful, and sometimes that makes it a bit more squirrely. And also it can elongate the process. So, it can be done in both ways, and has been successfully done in both ways. And certainly the larger the transaction becomes, the more complicated it becomes, the higher the value, in our opinion, of having an investment bank or broker behind it.
Great. So Bob, as the second investment banker, so I get a phone call from a practice. I convince them, now that I've heard David's view on it, they definitely need an investment banker. They pick you. Okay. What is it that you do? And then I'm going to ask Kim the same question from a legal perspective. What is it that you do first, get them ready? What do you need to do?
So you probably never heard me say this, and David hasn't either. And in all the transactions over the years that I've done with David Williamson, I probably haven't said this enough, but I agree with you 100% on what you said on the first part of that about education. And I think you know this too, Andrew, from a lot of your physician clients. Again, this is all I've been doing my whole career, is working with physicians. And I've come to the conclusion that there's, when we first get, when the docs first reach out, there's 2 totally separate, distinct steps in working with physicians to do it the right way. And the first step, which they're completely separate. The first is education. And as David said, I think that, we all know physicians are smart. They're highly intelligent in that they're good decision makers if they have the right information. Sometimes they think they know everything and they don't have the right information, and then that leads to bad decisions. But if they get the right information, they seem to make good decisions. And so that first step of educating them is the most important, because every group is different. Every group of doctors, every market, today is different than it was 3 months ago. It'll be different than it is a year from now. So really educating them on the process and what the opportunities are, what the strengths and weaknesses of their practice is, that's the first step. Then and that helps get some kind of expectations, that the first round of setting expectations. And if you get to that point to where, okay, they're educated enough on some of the opportunities, they have their expectations in the right spot, then you go to step 2, which is as Scott went through, rerunning the process and going through the process. But you don't even, and I've had a lot of clients over the years that never even get to the running the process to that second phase, because it's, in doing the homework of educating them and going through all the opportunities, they find out that either the timing's not right, that their practice has some things that aren't right, and that their expectations are not going to be reached, which, and has happened a lot in the last 5, 6, 7, 8 years with a lot of the different, in a bunch of different specialties, with a lot of the private equity deals.
Okay, that's a tall order of things to do. Kim, legally, what do you have to do?
Well, when clients come and say they want to sell to, any buyer, the first thing they should do is get their own house in order before, they start letting the realtors in. Checking their documentation, and we always recommend that they do their own coding and chart review, because a lot of times buyers will do that and in their diligence, and that's really not the best way to find out you might have a huge compliance issue and you've been coding wrong for 20 years.
Yeah, makes sense. And I don't know any good coders out there. But maybe we could use sign. I'm just joking. So it all comes together. Okay. All right. Valerie, where are you? Yeah, you are. I was very interested in your presentation about accreditation. That's not something, once we have like a de novo center and we do our legal stuff and it all gets set up, we don't really deal with that. And it was interesting to hear. And so important, especially in some place, probably in most states where it's deeming, and if you don't get accredited, you can't open. So what, like it's the day that, whether it's Joint Commission or whomever, Valerie's from the Joint Commission, you come to the door of the facility. Who do you expect to be there to help you during that accreditation day?
Yeah, this has been a great symposium, and thanks for inviting us here. Well, when I get asked that question, sometimes there's a variable. We have a blanket answer that attendees should be able to address leadership responsibilities for planning, resource allocation, management, oversight, performance improvement planning. Persons there that can support speaking to who carries out the organization's mission and strategic objectives, leaders of the medical staff. But breaking that down, because that sounds like a lot, we work with large healthcare organizations that have a plethora of resources and staff, and very small ASCs where it's the physician owner, their administrator, their clinical director, and their medical staff. So what I always give pointers to or tips to our organizations pursuing accreditation, or any organization pursuing accreditation with any org, is have the people that can answer the questions that the surveyors are going to be looking for. Think about what you prepared for in the standards. You're going to want to make sure performance improvement, your infection prevention planning. So have the persons teed up, whether they're there in person or virtual, that can answer the questions that'll be asked. But when our team shows up, and this may go into another question that may be of interest is, for a deeming survey, per CMS, we show up, we're in your lobby, and that's when we are there for your survey, as opposed to a non-deemed survey where you would get a 30-day notification for your initial, and then 7-day prior notice for a non-deemed survey for a resurvey. So there's a little setup there, but with the deeming, it is always unannounced. So just who's going to be there? You just prep and prepare.
So it would be useful for the 300 plus people that registered to put like a location device on your car so they know if you're just going to show up. Is that right? Yeah.
Yeah, there you go. There's a workaround.
Well, thank you to the Joint Commission for helping us understand that. And by the way, if you haven't listened to Valerie's presentation or any of the presentations, they're going to be published on our YouTube channel and this session too, so you'll all be famous. And people watch it year in and year out. I see people still going to ones from years ago. So that'll come out at about Monday or Tuesday. So the investment bankers and David, you really want to listen to Aaron Mirsky's talk on current issues affecting valuations in healthcare. Aaron, where are you? There you are. Yes. I have to get a beard like that. I just have to. I don't know how, but I need to. So Aaron, my question to you is, you mentioned during your presentation, you did it very fast because you were listing a lot of criteria that can affect the valuation of a facility. And you mentioned the age of physicians. It seems to me, I'm sure people could disagree, that more of the centers that are being sold now, and Scott and Bob, we've had this. It's an aging demographic inside the facility. Some of the centers that got sold earlier on seem to be younger. How does that really affect it? And why does it affect it?
Yeah, Andrew, that's a great question. So, and I spoke about this a little bit in the context of thinking about future cash flow or sustainability. So a business, whether it be a practice or a surgery center with an age, the utilizers or physician providers that are skewing younger, potentially have longer working years ahead of them. And so if you think about the life cycle of the business, the more surgeons there are in a surgery center, the more physicians there are in a practice. With the demographic that sort of skews younger, you could think about the future profitability of the business as having more continuity and sort of being less risky, if you will, as opposed to someone who is a year or two from retirement. And that wouldn't necessarily. So that said, to answer the question, all else equal, older, closer to retirement, et cetera, would be more risky or potentially less valuable than the alternative, than sort of skewing younger. That said, I've seen very many businesses with a plan about how to manage the life cycle, with a model of physician workforce, surgeon workforce, sort of replacement, keeping the surgery center context, keeping partnerships or LLCs, the membership fresh, and really thinking about some of those things to manage the life cycle, such that when it does come time for a transaction or a recap or whatever it might be, to the extent there are older physicians, surgeons, it's really not a big deal. So I think that's part of probably what maybe Bob was talking about with education of, what you do before a transaction, and that in a lot of cases, everyone's busy working in the business, and, those kinds of things haven't happened yet, but are very doable and manageable.
So David, I saw you listening aggressively. I get Aaron's math risk calculus. Is that how you see it as a buyer?
Well, I think that, in the backdrop, what happens kind of every month of every year is you really have to anticipate, certain things within a practice or within a surgery center partnership where you know that a physician is going to be retiring in a certain number of years, or a physician in a practice, tells you that he's got a couple of years or she has a couple of years left. You have to backfill either on the ASC partnership side or add new physicians to the practice. And that's kind of a standard course of business. When it comes to a transaction, you just need to be aware of those things. And more times than not, there's not a huge group of physicians that are, a year away from retirement when the transaction is getting ready to close, because you would have to take that into consideration from a valuation standpoint. But it doesn't happen that often that you can't plan for that or can't put efforts towards kind of fixing that, if you will. And that's where, physician recruiting comes in, and physician to physician transfers on the surgery center side. You certainly want to get, kind of new partners involved, and they're out there, but it takes effort to make sure that you have kind of new life, new blood into a surgery center or to any partnership. And the successful ones are able to do that, and have long track records of continuous growth, even amidst life circumstances, if you will.
Right. All right. Excellent. Okay, I'm going to move us along to managing the revenue cycle process. On this one, I got a lot of questions that were too complex to give, and I apologize, and we'll get back to you, but they were dense. But where's Colleen? Colleen's a member of Garfunkel Health Advisors as well. And credentials. Why, you get your approval letter, you get your first reimbursement check from a payer. Is that where it ends? Do I need to really keep doing anything?
Yeah, it's crucial to make sure that you're maintaining your credentials. Once that approval happens, all healthcare payers require different revalidations and verification requests to make sure that the information they have on file is still active. If you don't respond to those, they will term you from the network, and you'll have to start that process over, and that could take up to 120 days in some cases or over. So you definitely need to stay on top and maintain those credentials.
Okay. But Michael, as somebody who runs a revenue cycle company, where are you? There you are. I hear providers in general, they're never happy with the net collection rate. I've never heard somebody say, I love my collection rate. It's the best, right? It's a little bit how I was feeling about the Yankees before last night. So what steps, just give me some bullet points. What can they do to raise it if somebody just calls you without you knowing anything?
Sure. And appreciate the opportunity, Andrew. It's been a great symposium. What I would do first is, review your contracts. And if you have your net collection rate measured, and let's say it comes in at 95, 95 in school was an A, right? And most of us would be happy with a 95, but a 95 net collection rate means that you're missing out on 5% of your revenue that you're entitled to collect. So Colleen's group negotiates the contract, so you guys may do it, and you negotiate, say, $1,000 for a procedure. Well, if your collection rate's only 95%, you're missing out on that $50. So you want to make sure you review all your contracts, understand your contracts, make sure you understand all your contractual rates. If you have carve-outs that were procured, make sure you understand those, and make sure you understand how we're being paid. Most payers will say we're going to pay you, a multiple procedure discount. So, they may pay 100% on the first procedure, 50% on the subsequent procedures, or something like that. Once you have that understanding of your contracts, conduct a reimbursement audit and ensure that, once you have your contractual rates, ensure that you're being paid appropriately. And then if you're not, maybe look into denials. What kind of denials are we receiving? on certain procedure. And it may come back to Colleen's group. Maybe the physician wasn't credentialed, or something wasn't credentialed correctly. That could be a problem. Maybe, they're doing a procedure that wasn't carved out. So, things like that. So make sure that you run through those, reviewing the contract, conduct the reimbursement audit, and then do a denial audit. If you don't have the staff or you don't have the bandwidth to do this, call a revenue cycle company such as AccuAn, and we can certainly provide it for you.
Okay, appreciate that. Allison, as somebody who's a member of our managed care group, and you're always arguing or negotiating with payers, why do they care if your credentials are really right? Once they sign you up and you're in their directory, why do they care if you get it right?
Well, they care because ultimately it's the gateway to the world of managed care. They need to confirm that their participating providers and facilities are up to date on various requirements, whether it's federal requirements, state requirements, the plan's own requirements. Is their licensure correct, up to date, their education requirements, insurance coverage? They need to make sure it's all there. And at the end of the day, yes, this can impact, like Michael and Colleen were saying, it can impact if something is wrong with the revenue that's coming in. But at the end of the day, like Colleen just mentioned, if something is wrong and they're going to keep monitoring it every few years, if you don't credential or re-credential properly, you can end up getting kicked out of the plan. And it isn't always so simple to get back in. So you really want to make sure that you're on top of it.
Okay. All right. Moving along to selecting, implementing, and controlling AI in healthcare, which had the best moderator. I just want to mention that. But I got some funny texts from people who are either thinking about AI or in the midst of an AI nightmare. But I left that session with some cliffhangers, which I want to hit. Terrence, you get your AI hooked up, client loves it. Somebody accused me of being too negative, but that's true, I am too negative. But they hook it up and it's working great, right? Like, there's no problems. And then the vendor comes along after the 2-year term and says, I'm jacking your rates up by 50%, and now you're totally desperate on them. What are the kind of things you do when you review a contract in our technology group?
Sure. Thanks, Andrew. No, that's actually a common problem. If the solution is great, there are always transaction costs whenever you're switching technology vendors. But the transaction costs are usually higher in an AI solution because you're integrating data, you have to fiddle around with it to make it work. So yeah, vendors will often squeeze our clients afterwards. I just got a contract where it was a 3-year contract and now it's over, and the client loves the product and the prices are going up almost 50%. So and the vendor's saying it's because it was a 3-year term and we added a lot more functionality. Either way, you should deal with this. You should negotiate rates before you sign the initial contract. When you're an early adopter is the best time when you have the most leverage to get lower rates. So you lock in an annual cap. You try to get a cap during the term. And then even after the initial term, you put an annual cap on fees. You got to do it up front. You don't have much leverage at the renewal time. And the other thing is, if you really, because there are alternative vendors that will be coming out, but because you want to you don't want to avoid a disruption, Andrew, you often put in a transition right saying upon termination, if we can't come to agreement on rates, we can continue using the product for 90 days to 1 year, where I look for an alternative replacement. So there are ways to deal with it contractually to reduce that risk.
Yeah, and I would also kind of add, because I walk by your door all the time, when so many times providers will say, well, I signed the AI contract because they told me I couldn't make changes. I guess your whole career is about making changes to those contracts, so they happen.
Look, Microsoft is hard to budge. The big vendors, Snowflake, even Snowflake and the big vendors out there, Nuance, still negotiate. Everything is negotiable, especially if you have a decent enough contract size. So yes, I've been on many calls where the vendor gets on the first call, says, I've never seen such a marked up contract in my whole life. And, it doesn't bother me at all. I say, thank you. there must be a lot of bad lawyers out there. But yeah, no, you negotiate everything, Andrew. You try
Okay.
it.
All right, Hassan, you get a call from David Williams. One of his centers is having an AI nightmare. It's clinically, let's assume it's just making mistakes that are suddenly out of bounds. Okay. And you're probably going to get that call at Friday at 3 o'clock when you're heading out. Okay. What do you tell David to do? Like, how do you start to mobilize that? What's the story?
I guess it depends. So there's three concerns that have come about recently when it comes to AI, problems. There's hallucinations, there's errors, and there's biases. I think the first thing that I would urge anyone, David, to do would be to figure out, is this a true misrepresentation and just factually inaccurate? Is it an issue that occurred in the data itself or the algorithm that you were running? And where does that issue reside? Meaning, is it within your own private AI instance, or is it, something that, a vendor was supporting you and it's at their end? So really trying to get to the crux of what the issue is with the AI itself, where it resides. And then obviously you mobilize the right people being your legal team first and foremost, as well as your technologists that are either supporting and building that algorithm and maintaining the data warehouse or the data lake that sits on top of it, or a third-party vendor that you've outsourced your AI instance to.
Okay. So, and that's, we talked about this and then we have just two more questions and we'll be done there. I know we're past the time. But I talked about this, or this was talked about on our session. AI fails, right? You can almost bank on that. Is that right?
And AI, like any technology, will fail. It just depends on what are the guardrails that you've put around your AI, and can you, try and minimize the impact, if and when it happens. It will happen if and when.
Crazy.
What is it? Yeah.
So, okay, so we lost our resident psychiatrist. That's what he said he had to run. I understand these are stressful days. He's probably getting pulled all the time. So, Marianne, I'm going to ask you, as the head of our of GW's employment law group, to be both lawyer and a therapist, which I think you have to do in your role. Where is the dividing line between somebody who just got stressed out and had a bad day, and you'll do some things which you'll describe, and where this person cannot come back? Like,
Okay.
like what's the degree? Like, what do you look for? And I'm sure you've gotten calls where you've sometimes said we can work this out, and sometimes you said no. What is that line for you?
So usually I'm looking for more of a pattern, but I will tell you, it's important that clients or doctors reach out for the assistance kind of paper trail before you have to pull the plug on an employment relationship, right? Because there are things that you might flush out during a discussion with an employee to understand what's going on. So for instance, the employee who's having severe anger management, disruptive in the office, right? A lot of times I'm called when you're ready to terminate, and I'm going to have a bunch of questions about, what's been going on. I usually will say, treat this initially as a performance issue. Hopefully you have policies in place with codes of conduct, things of that nature. And you would sit down and say, okay, we've noticed this, this, and that about your performance. Do you have an explanation? These are our expectations. If it's really serious and bad, I mean, like somebody assaulted someone, of course, I'm going to tell you to terminate. If it's something shorter that, and it's something particularly that others have engaged in, right? I'm not going to say pull the plug. You might have a discrimination issue if you treat one person different than the other. I will tell you, don't perceive the person as having a mental health issue. Perceived disabilities, and if you treat a person with as though they have a perceived disability, they then have a protected category. It might just be, they're nasty, they're rude, they're insubordinate, and you're going to counsel them, create a paper trail so that when you make the termination decision, you are protected. Now, during that meeting, they may turn around and say to you, I have a mental health issue, I started a new medication, right? And then I'm going to give you advice about, okay, you're going to need to engage in a dialogue about reasonable accommodations. Now, if I pretend to be the psychologist, psychiatrist, right, I'm also going to try to be supportive. I'm going to refer them to EAP for assistance. But as the employer, do not, and I talked about that during my session, do not cross over a line. You're not entitled to a lot of detailed information about the diagnosis. As soon as they say, well, maybe my behavior is related to a medical condition, then you start the dialogue and see what accommodations could be made. But I will say, just because you have a medical condition doesn't allow you, right, to just have a bulletproof vest on to go around being nasty to all employees and obstructive, right? You don't get a free pass for all of that. So
Interesting. So you really do have to be both a therapist and a lawyer to do what you do. Okay, well, we are now officially over time by a lot. So I know this was hard to do with so many people and such different varied, but I really do think that today's session was the best that we've had. We've been doing this for 11 years, and it's because of everyone listening in TV land and all our panelists. So thank you. All materials will be distributed by Monday or Tuesday, and you'll all be YouTube famous stars by next week. So have a great rest of the day, and thank you for everything.
Thank you.
Bye-bye.
Bye-bye.